Preterm labor is defined as regular uterine contractions causing cervical changes before 37 weeks of gestation. The strongest risk factor for preterm labor is a previous history of preterm delivery. Bed rest and tocolytic medications are common interventions for preterm labor. No tocolytic drug has shown superiority over others. Placebo has shown 50% effectiveness in preterm labor studies. Cervical insufficiency involves premature softening or shortening of the cervix. Cervical insufficiency is often seen in women with prior history and is hard to detect in first-time mothers. Cerclage is a surgical treatment for cervical insufficiency and involves placing sutures around the cervix. Premature rupture of membranes is defined as rupture before the onset of contractions. Preterm premature rupture of membranes occurs before 37 completed weeks. Preterm premature rupture of membranes happens in about 3% of pregnancies. It is responsible for or associated with up to 1/3 of preterm births. Causes of premature rupture may include infection or early cervical opening. Vaginal fluid pH testing using nitrazine paper helps confirm membrane rupture. Amniotic fluid has a pH of 7.0 to 7.3, while vaginal pH is normally 3.8 to 4.2. Ferning test involves observing dried amniotic fluid on a glass slide for a fern-like pattern. Fetal lung maturity testing is considered between 32 and 39 weeks gestation. Tests for lung maturity include lecithin sphingomyelin ratio, phosphatidylglycerol, and lamellar body count. Lung maturity testing is not done before 32 weeks or after 39 weeks gestation. Delivery is recommended at 34 weeks or later if fetal lung maturity is confirmed. If lung maturity is confirmed but gestational age is less than 34 weeks, expectant management is preferred. Expectant management includes antibiotics, corticosteroids, and fetal monitoring. If fetal lungs are immature, wait until 36 weeks before delivery unless complications arise. If infection occurs with membrane rupture, immediate delivery is required regardless of gestational age. Risk of fetal infection increases with the time between rupture and delivery. Preeclampsia is a progressive disorder involving maternal and placental vascular dysfunction. Preeclampsia affects about 3 to 7% of pregnancies. The cause of preeclampsia is unknown. Preeclampsia presents with high blood pressure and proteinuria in the late second or third trimester. Eclampsia is preeclampsia with seizures. Severe preeclampsia signs include systolic blood pressure to 160 mm or diastolic 110 mm. Proteinuria 5 grams in 24 hours or 3+ on dipstick is considered severe. Oliguria 500 milliliters in 24 hours is a severe sign. Visual or mental changes are signs of severity. Cyanosis, pulmonary edema, or respiratory distress suggests severity. Upper abdominal or epigastric pain indicates possible liver involvement. Elevated liver enzymes and thrombocytopenia are signs of severity. If severe signs are present, delivery is urgently required. Blood pressure is controlled with labetalol or hydralazine. Magnesium sulfate is used to prevent seizures. Maternal symptoms usually resolve after delivery. Seizures may still occur after delivery, so monitoring is essential. Neonates born to mothers treated with magnesium may have high magnesium levels. Neonatal hypermagnesemia may cause respiratory depression, lethargy, floppiness, hyporeflexia, and poor feeding. Treatment of neonatal hypermagnesemia is usually supportive. Rarely, calcium and diuretics are used. These infants may also have low white blood cells and platelets that resolve on their own. HELP syndrome includes hemolysis, elevated liver enzymes, and low platelets. HELP syndrome may be a severe variant of preeclampsia. Early diagnosis of HELP is critical due to its 25% morbidity and mortality. Elevated D-dimer may indicate progression to HELP syndrome. HELP treatment includes seizure prevention and blood pressure control.